Well, welcome back to midterm 1, and what we want to do in this final module of the musculoskeletal system is talk about joint and muscle. Joint and muscle is what we're talking about. Probably the best place to start right now is just to first I'll talk about joint terms. So let's go ahead and get started and talk about some joint terms. Couple words here that I think we really need to know. Articulation. Articulation is basically another word for a joint. Okay, so whenever you see the word articulation, articulation would be a word that means joint. Now, what I see here on the right side of the image, let me get rid of myself here. That way you don't have to worry about me sitting right here in your way. What happens, articulation, this is an articulation over here, and this is what I call a synovial joint, okay? And I'll talk about synovial joint in a little bit. And the synovial joint, let me just mention the parts of what a synovial joint is. Let's say this is the end of any bone, and this is the end of another bone right here. What happens is I have one bone meeting another bone, okay? And what happens, it creates a joint, and the joint would be this area inside here, okay? And that's the articulation between these two areas right here. This would be cartilage at the end of the joint, that'd be cartilage at the end of the joint. What happens is that joint is held together by ligament or dense connective tissue, which is called a capsule. See up here it says ligament, stuff like that. So this is basically ligament or capsule, and that holds one bone to the second bone. Well, inside that capsule is a membrane. Okay, and if I look here, here's a area right here. See that little bluish area right there? That's called the synovial membrane. And that synovial membrane has a specific purpose. And what that synovial membrane does, it produces fluid that fills that light blue area in between. So basically, what happens is what we're creating here, okay, in this synovial joint is a synovial cavity. So that whole area between the two ends of the bone, enclosed by that capsule, which it holds it together, which is basically by ligament, is a space inside there which is filled with that fluid. So that's the synovial cavity inside. That synovial cavity is filled with synovial fluid, and that synovial fluid works because it's sort of slippery. It allows the cartilage in one end of the bone right here and the cartilage to slide very nice and smoothly against each other. Okay, and so that's what that synovial fluid does. It's sort of like slippery type of a fluid. Sometimes when people have a significant arthritis, they can actually inject the joint with a oily material, because what happens is maybe they need a little bit more lubrication inside there. And they could, there's a number of different things, Hyaluronic, Synvis, stuff like that, they could inject inside there, inside the joint, that provides a little bit more of a lubrication to make up for the synovial fluid. So this joint, when we look at that, this whole configuration that we have here is called a synovial joint. It's called a synovial joint, and the synovial joint is lined by that tissue that called synovial membrane that makes synovial fluid. Okay, and that's what we see in regards to what's called a synovial joint. Most of the joints in the body which are movable joints are the synovial joints: your shoulder joint, your knee joint, your ankle joint, your finger joints, your elbow joint, your hip joint. All these joints are mostly synovial, are synovial joints. Okay, and so the synovial joints are the ones that we usually think of as joints. There's different types of joints. I'll talk about those in a little bit, but those are called synovial joints. Okay, synovial joint has a synovial capsule that's lined inside with the synovial membrane. That synovial membrane makes synovial fluid, which fills that synovial space, or that synovial cavity inside, and that creates what's called a synovial joint. Okay. Now bursa. Let me get rid of my scratches here, so I get out of the way of my bursa. And this would be what we'd see in a shoulder. Okay, in a shoulder, what happens is, so here's that we talked about, that's the acromion, that little thing on the top of the shoulder, and here would be the scapula right here. Here's the clavicle or the collarbone right there. Right below that acromion, here's this little blue thing right there, and a bursa is basically a sac. Okay, and what the sac is filled with has a synovial membrane, just like we saw in the joint. Guess what that synovial membrane does? It makes a synovial type fluid that fills that sac just a little bit, and that allows things to slide. In other words, if you look underneath here, this is a muscle right here. Okay, and you don't have to remember that, but that's called the supraspinatus muscle. It sits right underneath this acromion and on the top of the humerus, which is the upper arm bone right here. Well, I want to protect that muscle from the bone. I don't want that muscle rubbing against the bone. So what happens, the body has these little sacs in it, they're called bursa. And that bursa, or bursae, would be, would be plural. What happens is that's filled with a little bit of fluid, actually got a little bit of a cushion, sort of like that bubble wrap that you see like when you get in packing stuff, okay? And that's what that bursa really does. It sort of provides a little bit of a cushion, or a little bit of a protection for that tendon that's sliding up underneath that bone, so that bone doesn't rub away the tendon, okay? The word ligament. Now this is something that people frequently miss, and they go back and forth, and they actually have it wrong in many cases. Ligament is actually dense connective tissue, which is nice and firm tissue that connects a bone to bone, connects bone to bone. Okay, so ligament only connects bone to bone. When they talk about like they tore their anterior cruciate ligament, cruciate means crossed. Inside the knee, there's these two crossed ligaments. One's called the anterior cruciate, the other one's called the posterior cruciate, and they sort of cross each other like a little cross, and they prevent the tibia, which is, we know, the larger lower leg bone, and the femur from moving backwards and forwards on themselves, anteriorly and posteriorly. And so that's what the ligament does. A ligament is actually something that sort of like helps to guide movement and prevent excessive motion and stuff like that. But basically, they attach bone to bone. We talked about that synovial joint in a previous picture over there. What happens at synovial joint is encased in this ligamentous capsule, which holds the two bones together. Now that differs considerably from what we call a tendon. A tendon is something that actually connects muscle to bone, connects muscle to bone. If I'm looking down in here, okay, see right here, this is the biceps muscle right here. Biceps muscle. And the biceps muscle, it's called biceps because bi means, as we all know, means two, has two heads to it. And this diagram, I don't quite like it a lot because it only shows one of those heads, okay? And this is one head of the biceps. And see right here, there's a tendon, and the tendon connects the biceps right to the top of the joint, right where the shoulder attaches. There's also another part of this biceps tendon that goes right here. Now this area right here is called the coracoid. It's a little finger-like projection that comes out from the front, the anterior portion of the scapula, and this short head of the biceps attaches right there. And how is it attached? It attaches by tendon, because tendon attaches muscle to bone. Ligament attaches bone to bone. Tendon attaches muscle to bone. I think that's something that's really critical to be able to understand, okay, because those words are used commonly in medical terms. Okay, and then if I look at the last thing, and again, let me just go back and show you what I'm talking about again a little bit more here. This is that anterior cruciate ligament and posterior cruciate ligament that we saw before. And what happens is we see our posterior cruciate right here, and the anterior cruciate, you can actually see the tip of it right here coming across the front. See, it's sort of across the middle of the joint. So it's connecting the femur up here with the tibia down there. Okay, so that's called ligament. These are the collateral ligaments. That right here would be called the lateral collateral ligament. Okay, and this one's called the medial collateral ligament. Okay, on this side. See how it comes around this side, it comes around this way. This one you can actually feel, the lateral collateral ligament. Medial collateral ligament is really sort of broad and flat. If you take and you cross your knees, okay, or you cross your legs, take your, it's hard to demonstrate here in class to be able to demonstrate, but if you're sitting and you put your right ankle and you cross your legs and it's on the top of your left knee, okay, if you feel the lateral aspect of your knee, you're going to feel this cord, feels like a pencil in there, and that's what you're feeling. You're feeling that lateral collateral ligament, which is sitting right in there. So again, ligament connects bone to bone, tendon connects muscle to bone. It's very important to remember. And again, here's another situation where we see muscle being attached to bone, which is basically a tendon. Okay, so this would be, shows a muscle and tendon attaching. Here's this one over here would be at the elbow. This one would be at the hip. That's pretty, it doesn't show it very, but you can actually see what happens. There's the tendon attaches. There's a tendon attaches to the bone. Okay, so tendon attaches muscle to bone. Ligament attaches bone to bone. Now this is another type of joint. Okay, I mentioned that we talked about a lot about synovial joints, but if you actually start to look at skulls and stuff like that, you see all these little squiggly lines in here, all these little squiggly lines, okay? Little squiggly lines all over the place, and they're all over the place. These are called suture joints, okay? And these suture joints look just like this. What happens is, as the baby's coming down a birth canal, these suture joints are actually pretty much open. And it allows the cranial bones, which are basically, as we know, the bones that comprise the skull, allows the cranial bones to actually overlap each other a little bit. And that allows the baby's head to get a little bit smaller as it's coming through the birth canal to help mom out, okay? So as a result, then what happens is then once the baby is born, eventually the skull comes back and reforms as it should be. And eventually, as kids get older, these suture joints will actually start to fuse up. Okay, and they're filled with a fibrous material. And if you look at an adult, okay, basically there's not much in there. It's actually basically bone to bone, but you will continue to see, even in an adult, all these little squiggly lines all over there called suture joints. And again, they're all over throughout the skull. There's multiple little suture joints that we find all over in the skull. Let's get some combining forms out of the way and just get some words here. Ankylo means stiff, okay? There's a condition, something that's called ankylosing spondylitis. So spondylo means spine, okay? Itis means inflammation, as we know. So I know it has to do with some type of spine inflammation, but what about it? It's ankylosing. It becomes stiff. And this usually happens in males, and they're older, and they get what's called a bamboo spine. Because if you look at bamboo, there's like a piece of bamboo, and there's like a little joint, and a piece of bamboo, and a little joint, piece of bamboo, and there's a little joint. What happens is the area between the vertebrae in these people with ankylosing spondylitis starts to calcify. There's discs between there, and the discs start to calcify. So when you look at the back, it almost looks like a piece of bamboo, and the back gets stiffer and stiffer and stiffer. Sometimes people with joint injuries, they get an ankylosis. Osis means condition, stiff condition of a joint because they destroy the joint itself. Okay, so ankylo means stiff. Arthro means joint, arthritis, itis, inflammation of a what? Joint. Articulo also means joint. We talk about articulation means joint, but articulo also means joint. Burso obviously means bursal, like we talked about those little sacs, like we talked about in the last slide. Chondro means cartilage, okay? Sometimes people get a chondritis, which would be inflammation of the cartilage. Sometimes people, if they have like a car accident and they hit their chest against the steering wheel, they get some chest pain. What happens is the ribs come only so far, and then the ribs are attached to the sternum or the breastbone by a piece of cartilage. Okay. After that, there'll be a piece of cartilage that actually connects the ribs to the sternum. But right here, right where the rib meets the cartilage, it sometimes gets a little bit irritated or actually gets moved a little bit. And they call that a costo, because costo means rib, costochondritis, because chondro means cartilage. And they get that inflammation right where the costo rib meets the cartilage chondro. Okay, so that's something that you have to think about there. Ligamento obviously means ligament. Rheumato, we talked about in an earlier thing, which means watery flow, Synovo means synovial membrane. Now, we talked a lot about the synovial membrane, and that's that membrane inside synovial joint, synovial fluid. Synovitis would be inflammation of the inside of a joint where the synovial membrane becomes inflamed and it produces more fluid. That's what we see in rheumatoid arthritis. In rheumatoid arthritis, what happens, we have an autoimmune, everybody should know what self-immune, what happens, they have an immune response against their own synovial membrane on the inside of the joint that causes an inflammation of that synovial membrane that makes more synovial fluid, okay? So they get a synovitis, inflammation of that synovial membrane because of the disease. Teno obviously means tendon, and tendino obviously means tendon. So those are pretty simple. So those combining forms are relatively straightforward, I think, okay? Here are some suffixes. Desis. Desis, we've had this before. I just mentioned it before, as well as the second one, stenosis. But desis means to bind or to tie together. Okay, to bind or tie together. Okay, and basically, sometimes when people have a joint injury, and the joint becomes worn away, and the cartilage. Think about cartilage. Once cartilage is gone, guess what? Bye-bye, ain't coming back. No cartilage is going to regenerate itself, at least right now. So as a result, what happens is now this cartilage becomes worn away. We get sometimes worn down to raw bone, and sometimes that causes a lot of pain. Now we have raw bone rubbing against raw bone. So a lot of times what happens surgically, what they do is they do what's called an arthrodesis. They do an arthrodesis. And that arthrodesis is a situation where they actually go in and surgically remove whatever cartilage is there, and then they take the two raw ends of the bone, stick them together and run them through screws or plates or something to hold them together until those two raw ends of the bone will actually fuse to each other like one bone. So now there's no motion at all, and that's called arthrodesis. Again, so it's to bind or tie together. Stenosis means narrowing. Now, what does this have to do with joints? What happens is sometimes people get what's called a lumbar canal stenosis. And what happens in the lumbar region of the vertebrae, okay, in the lower back, those 5 lumbar vertebrae, okay, what will happen is inside, okay, we have a body of a vertebrae, and then we have an archway on the back. and you have a transverse process here, and this you have a spinous process, which is that bump that you feel coming out the back when you feel down the middle of your back. Well, inside this arch is the spinal cord. Sometimes inside this archway, the archway becomes narrowed and starts to put pressure on the spinal cord, and that would be called the lumbar canal stenosis, because that canal on the inside of that archway becomes narrowed. Okay, so stenosis means narrow. Okay, I just bring in a couple words for you because these are something that may come come up, one place or another. Just mention I'm not going to spend much time because this is something that's more addressable in anatomy and physiology. Something we have what's called a synarthrosis. Now, synarthrosis is basically like the suture joints. The suture joints are not meant to be moved. Okay, once they fuse, they're not meant to be moved, and that's called a synarthrosis. Syn means together. Okay, amphiarthrosis are joints that are slightly movable. Okay, and what we see right down here, we see the pelvis coming together, and right in the middle of the pelvis, okay, right at this spot, okay, there's a disc of cartilage. It's called the pubic. This is called the pubic symphysis. This area right here, and there's a cartilage right there that holds the pelvis on this side to the pelvis on this side. It's slightly movable. It moves a little bit, allows the pelvis to rotate just a little bit. So joints that are slightly movable are called a synarthrosis, or excuse me, amphiarthrosis. Okay, and then we also have what's called a diarthrosis. A diarthrosis, like we talked about, the synovial joints. These are freely movable. They're all synovial joints, and we have all kinds of different shapes. Of different saddle shapes, ball and socket shapes, a hinge joint, all different types of joints, okay? And these are different types of joints that we have. Synarthrosis, immovable. Amphiarthrosis, slightly movable. Diarthrosis, freely movable, okay? Again, this just goes back to the synovial joints like we talked about, and all synovial joints are freely movable. And we know we have that synovial cavity. You can see that synovial cavity inside here. Here in this image, it's sort of imaged as that darker cranberry color that's inside the joint, okay? Both ends are covered with cartilage, okay? So we have cartilage over here, and cartilage covers the bone, the bone on that side of the joint, okay? And what happens is that the cartilage allows a slippery movement because the ends should be smooth. When people get osteoarthritis, what happens is just by wear and tear, by everyday moving it through a lifetime, that cartilage gets worn down. It's called osteoarthritis. And what happens is basically, again, like I mentioned before, the cartilage doesn't regenerate itself. It doesn't repair itself. Once it's gone, it's gone. So that cartilage, when we start out and early, like all you guys, okay, and younger, is very smooth and slippery. So it doesn't bind up, okay? And also it reduces the friction because it is smooth and slippery, okay? And that synovial fluid that's produced by the synovial membrane joint covers the top of that, which provides a little bit more of a lubrication, like an oily surface that's outside the joint, okay? And this is what we talked about before with the articular joint capsule, just to re-emphasize that. And basically the synovial cavity would be inside that capsule. So we see ligament right here, or capsule, holding the joint together. Inside is lined with that synovial membrane, okay? And that capsule, which is the outer fibrous layer, is dense connective tissue. And that actually blends with the periosteum. We talked about periosteum. That periosteum is that membrane that covers the bone, except where there's cartilage. And what happens is the ligament then blends with the periosteum to make a nice firm attachment, here and here and here and here to the bone, okay? And it provides a lot of strength, okay? Then we have that intersynovial membrane that you can see. It's sort of like a pink layer in there. It's a very small, thin layer that produces the synovial fluid, and the ligaments will support the capsule. And that's what we talked about before. So that's just called a synovial joint. That comes up very frequently because, again, the majority of the joints that we actually worry about are synovial joints. The ones that usually cause a problem are synovial joints. And what happens is because that synovial membrane makes a synovial fluid, okay, that provides that film over the articular surface that allows it to be smooth. Well, if they sometimes here they're doing what's called, oh, that's a good word. Okay, let's just go with this word, see if you could fill it in. Arthrocentesis, because centesis is taking a needle, doing a surgical puncture. You numb up this area right here, you clean it off with a lot of antiseptic solution for a while to make it nice and sterile, because you don't want to stick bacteria inside the joint, stick the needle inside the joint, and then when you do that, it actually draws out the fluid, okay? And the fluid that you get, that synovial fluid, is usually very viscous, clear, and pale yellow. So if we look over here, that's what it looks like. It's a very, very pale yellow, okay, like almost like a dilute urine, but this is slippery. Where urine is watery, this is actually slippery. Also inside are what are called phagocytes. Now phago means to eat, cyte we know means cell. These are actually white blood cells and stuff like that that will eat up the bacteria and stuff like that that might just for some reason get inside of a joint. They clean up microbes as well as debris, dead cells that are actually floating around the cell. These phagocytes could go in and eat it. And again, what this synovial fluid does, it's a friction reducer and lubricator because it's sort of oily and slippery type. Also, what happens is because the cartilage doesn't really have a blood supply, inside the synovial fluid, there are various nutrients, okay? And as the joint moves, it actually pushes the synovial fluid down in small little micro cracks within the area of the cartilage that actually provides some lubricant, or actually supply some nutrients to the cells, the chondrocytes, cartilage cells that are in there that aren't getting any nutrients from blood because there's no blood supply that's really in there. Also, what happens, it removes waste from the chondrocytes, and just like, you know, the cells that are inside the cartilage, and the thing about the cartilage cells, different type of cartilage, there are very few cells in what we call matrix, a lot of material around the outside, so it doesn't need a whole lot. It's like a very underpopulated area, okay, and so therefore it doesn't need a whole lot of nutrients to be able to survive, but does make waste. So it needs the nutrients, it has to get rid of the waste that the cell does, and it does that through the synovial fluid. Okay. This is a word that I read that comes up in our vocabulary a lot. Articular disc or menisci, okay, a meniscus, okay? And what happens is inside some synovial joints, we actually have a different type of cartilage, a fibrocartilage that's between the articular surfaces. And what this purpose of this meniscus would be, it modifies the joint surface shape to allow a better congruity. So what happens, it fits better, okay? So therefore, what that does, it provides stability of the joint, also helps to direct the flow of synovial fluid. Now, if we look here, okay, let me just try to annotate what we got over here. This is the femur right here, okay? And you can actually see that this is actually the knee, because it says knee meniscus. If I look at the top of the tibia, it's relatively flat. It's only very minimally concave. Where if I look at those femoral condyles, because we all know what condyle means, is very round. How do I fit a round thing into a relatively flat area? What they do is the knee has these menisci, has a medial meniscus and a lateral meniscus. What happens is that meniscus is very thick around the rim, around the outside, and gets very thin on the inside, okay? And as a result, what happens is that meniscus can be like this on the outside, very high, and as you get closer to the inside of the joint, it becomes thin. Now that deepens that socket. So that's what the meniscus does. It deepens the socket so that those femoral condyles sit inside of a deeper socket inside there. We have them very similar to one like this in the shoulder, okay? If sometimes you hear, oh, pitcher tore his labrum. And that labrum is the area, is the meniscus that's around the shoulder joint, okay? That really helps to keep the head of the humerus, and we know the humerus, the upper arm bone, inside that articular surface of the scapula, which is called the glenoid fossa. And this one right here is just, a lot of times what happens is the medial femoral condyle is larger than the lateral, and the medial meniscus is sort of C-shaped and a lot more open. And what happens is we do have some rotation of the medial femoral condyle inside here, as well as just a flexion extension. And that rotation sometimes chips off a little piece of that meniscus around the rim that causes, of course, that, oh, they tore their meniscus. Okay. It used to be a big problem. Now people go in, they arthroscopically go and remove a little fragment or try to fix it up again. The meniscus doesn't repair itself. So once it's torn, it's torn. You can't repair it. Okay. Bursa. And here's that bursa that's right here. Again, here's that acromion right there. And we could see that here's that muscle they talked about, that supraspinatus muscle that sits right in there. And there's like a tunnel underneath that acromion process of the scapula. This would be the clavicle right here. Here's the clavicle right here. Put clav right there. And here's, and so what happens is I need to protect that subscapularis muscle, and the way it does is it puts this little bursa or this sac just underneath the acromion so that it doesn't rub, so the muscle doesn't rub against the bone, which then causes a problem. So the bursa, has synovial membrane in the side, which makes that synovial fluid. Okay, it's not in the joint, but it's close to the joint. Okay, so the shoulder joint would be up in here, and that's between the muscle and the and the acromion right there. And this allows the sliding of adjacent tissues without rubbing on things. So we could find this in certain areas where there are tendons or ligaments that we don't want them to be worn down. It's like if you take two sticks and rub them together, eventually the sticks will become very smooth. You don't want that to happen to the muscle. So to protect it, they put these little sacs in there called bursa. A couple common locations. There's one over the elbow joint on the back of the elbow, which is called the olecranon bursa. There's one in front of the knee, which is called the prepatellar bursa. And this one up in here would be called the subacromial, because sub means below, acromial means the acromion or the top of the shoulder. Okay, and that's what we saw with the bursa. Let's talk about some pathological conditions just for the heck of it for the joints. Ankylosing spondylitis I talked about before as a big problem. Okay, and that's one thing that we see where the back becomes progressively stiffer. Okay, I should have had a picture, but I forgot about that. Maybe it'll come up a little bit later. But that's called ankylosing spondylitis. Again, it usually occurs in males. It's something that's basically there's actually a certain genetic marker that they're able to determine for the ankylosing spondylitis. Now this right down here, it looks like a really lumpy hand, and it is. Okay, and this right down here is what's called Gaudy arthritis. Okay, now gout. Okay. Gout is a problem with the development or the deposition of uric acid. Now, uric acid is a breakdown of proteins. And sometimes what happens is this uric acid, which are little like spiky crystals, they will form. And we see a collection right here. We can see a collection over most of the joints. Those are actually starting to leak a little bit. And that's what we see sometimes in this gouty arthritis. That what happens is if these actually, I've seen a number of patients with this, and sometimes there'll be a little hole. If you squeeze it, these little glistening crystals will actually come out of the joint, okay? And that's what we see in the cases of gouty arthritis, okay? Now, that's usually not what we see. Just a word, you have to remember this, but these, when I see something like that, they're called, let me use a different color here, they're called tophi. And these lumps and bumps, they could be on the ears, they could be over the joints, they could be multiple different places, okay? But usually over the hand joints and sometimes over the, and frequently over the foot joints, very similar over the toes and over the fingers. But they could be in the ears, they could be behind the elbow, they could be all kinds of stuff like that. And these are called tophi, okay? But what we also see in gout is, and that's back behind there, so I can't get rid of that. Okay, but that's my ankylosing spondylitis, I think, behind there. Somehow it got in the wrong place, and that's where that spine would be messed up. Okay, let me get to this right here. This is, so we got, let me, before I finish, I apologize for the slides being a little bit over. What happens is the gouty arthritis also produces something called gout. And gout sometimes will cause a real significant rip-roaring inflammation in a joint, okay? What happens is these little crystals, and they look like little spikes, look like little spears. You can see them underneath the microscope. What happens is they get deposited in the joint. And what happens is the body says, that shouldn't be there, and they send white blood cells there. The white blood cells try to gobble them up. These things like shish kebab, the white blood cells, they poke through it because they're very sharp. They have a very sharp, pointy ends. They poke through the white blood cells, and all the enzymes and acids that are in the white blood cells that help to destroy things that it eats up get released inside the joint, and it causes the joint to become significantly inflamed. And the joint becomes very, very, very tremendously inflamed, and that becomes a problem. Okay, and that's and if you've known someone with gout, the most common place that gout would occur would be in either the first metatarsal phalangeal joint or the big toe joint. That's probably about 80% of the gout that occurs is probably in that big toe joint. Okay. Now this image right here, now that I've sort of caught up correctly, is called osteoarthritis. Okay. And when we look at osteoarthritis, and let me just show you what we're talking about here. If I look at this joint right here, here's the joint space right here. Okay. And it's a normal space. What happens over here? The cartilage is gone. The joint space is really closed down and is very narrowed. And again, once cartilage is gone, guess what? It's not coming back. It doesn't regenerate itself. So they have to do, this is when they go with a total knee, they'll go in and take out the joint here. They'll put a plateau in here. They'll put condyles, you know, some type of a metal or ceramic condyle that covers in there. They just poke it up with pegs up into the femur, and they do the same thing here. They poke it down to the tibia, and now have an artificial joint. These actually work quite well. Okay, this happens also in the hip. We'll see this in the hip, where they have a hip replacement because of arthritis in the hip and stuff like that. But that's called osteoarthritis. Osteoarthritis. Okay, and osteoarthritis is a wear and tear arthritis of a joint. Okay, now this is rheumatoid arthritis. Let me get rid of my scratches here. This is rheumatoid arthritis. Now, I mentioned rheumatoid arthritis before. Rheumatoid arthritis, okay, is basically also called autoimmune. Autoimmune. Our body creates an immune response against our own synovial tissue. And what it does, it causes that synovium, that synovial membrane, the body attacks it. And it creates an inflammation of that synovial membrane. And what happens, that synovial membrane, because it's inflamed, starts to erode away bone, okay? And that's what we see. Now, if you look up, this is sometimes what we actually see in people with rheumatoid arthritis. They get a hand that looks sort of crazy. They get these joints that look, and usually it's usually a little bit more. Usually the fingers are are actually directed more towards the ulnar side, which should be over on this side. I think it's called an ulnar deviation. Same thing happens in the feet. They get a fibular deviation where the toes get deviated towards the lateral side. And that's because what happens is the joints become so full of fluid that the tendons that go over the top actually allow the fingers, the digits, to sort of slide laterally. Okay. Actually, this case would be slide medially because, again, the ulna would be on the medial side. Okay. So anyway, that's what happens. That's what rheumatoid arthritis, but it's an autoimmune condition that attacks our own synovial membrane. That's why a lot of times you'll see with people with rheumatoid arthritis, what they do is they give them biological agents. Have you tried a biological? What the biological agents do is they try to decrease the immune response of the body, which makes people a little bit more susceptible to other infections. In fact, if you listen to that really fast talk that they talk about, you know, when they talk about biological agents, you almost always hear about tuberculosis and stuff like that. And what happens is the reason why they want to know if somebody's been exposed or had tuberculosis is that tuberculosis stays and resides in the body. And when our immune system goes down, it allows that tuberculosis to activate itself like a sleeper cell. And next thing you know, it causes a problem. Okay, so that's a lot of times they give them either steroids. Okay, and the corticosteroids that they give either try to decrease the inflammation, or they give them other biological agents which actually work against some of the chemical mediators that actually produce the inflammation. Okay, and so that's what we see with rheumatoid arthritis. It's something you didn't catch. It's not a wear and tear. It's something that happens because the body's immune system gets a little off kilter. It goes haywire. Okay, so that's called rheumatoid arthritis. This is a bunion. Let me get rid of my scratches here. And another word for a bunion is called hallux, because we know that big toe is called the hallux valgus. And what happens is this is the first metatarsal. The first metatarsal is here, and the proximal phalanx is there. I could probably talk about 16 hours just on why this occurs. We don't have time for that. What happens is that first metatarsal starts to migrate more medially towards the midline. Midline would be here between the two feet. What happens? It migrates this way. There's a tendon right here that actually pulls the big toe, the hallux, this way. So we end up with this, what's called a valgus deformity. Valgus means, if I look at this is deformity right here. If the apex of that deformity, or the V, points towards the midline, it's called valgus. If the apex of the deformity points away from the midline, that would be called varus. Okay, valgus points towards the midline. Varus points towards away from the midline. So valgus towards the midline, varus away from the midline. Okay, so this is a hallux valgus, or a bunion deformity. Okay, very, very common. My wife just had some surgery for a bunion deformity. Recently, my friend of mine did it. So anyway, so I trusted him. He was a good guy. Okay, so if you need a referral, let me know. Anyway, no, I didn't mean. But anyway, that's called a bunion. Carpal tunnel syndrome. Okay, now let me get rid of this. Carpal tunnel syndrome. What carpal tunnel syndrome is, okay, is basically, if we look at the wrist, okay, and the wrist has this ligament that attaches from the carpal bones here to the carpal bones here, and that's called the transverse carpal ligament. Okay, and underneath that transverse carpal ligament are a bunch of tendons. All the tendons that actually flex my fingers, they'll bring my fingers in, curl my fingers down towards my palm, go underneath there. The long flexors or the short flexors. But guess what? That's not the problem. Okay, that's not really what really causes the problem in carpal tunnel syndrome. It's this guy right here. This guy right here, that yellow guy that sits right here. And that's called the median nerve. That median nerve gets down there. What happens is that carpal tunnel syndrome, this tunnel gets very narrowed for one reason or another, either inflammation or injury or something like that. And that ligament sort of binds it down and pushes against that nerve. Well, that nerve goes, if you look at it, the figures right here, it goes to the thumb, it goes to the index finger, it goes to the middle finger, it goes to this side of the ring finger to provide sensation. So what happens is people with carpal tunnel syndrome, they get numb in this whole area, both of the thumb, index, middle, and this side of the ring finger. Also, the muscles right here, let me do a different color, the muscles right here in the thumb are supplied by this median nerve. So people get a weakness of their thumb, okay? And that's basically what we see with the carpal tunnel syndrome. What they do with the carpal tunnel syndrome is they basically go and they split the ligament. They open it up, give them more room. They don't even sew it back together. They split it. Sometimes I put some corticosteroid or something that'll decrease the inflammation inside that tunnel, but they usually just go and split that. By splitting it, it releases the pressure on that nerve, and hopefully things will come back to normal, okay? And that's what at least that's what they're hoping will happen, okay? Now, dislocation, okay? Now, dislocation is where we have a joint that basically comes out of joint, okay? And that's what we're seeing right here. This is an elbow, okay? So we're seeing an elbow in this dislocation right here, an elbow dislocation. And what we're seeing here is here's the ulna right here. Here's the radius right here, okay? Here's the humerus sitting right here. Well, this area right here should be back in here. And guess what? It's not. Okay, so what happens is the humerus is this way, the ulna is this way. These are actually sort of interesting. If you ever watch a UFC, sometimes you'll see these people that land on their elbow, and you actually see the elbow will shoot back this way. It usually comes backwards, comes back to where it's supposed to go. It's like a shotgun, you know, goes back and then comes back in like that. And sometimes they get caught. There's a little piece of bone right there that gets caught in the back. It doesn't come back, and they just have to pop it back in. And then they have to put it in a splint and stuff like that for a long time just to let that joint heal. Because again, every time you cause a dislocation, what are you injuring? The ligament. Because the ligament, like I mentioned, is what actually holds that joint together. So if I have a dislocation, those ligaments are torn. When you get a shoulder dislocation, the ligaments are torn. Such as, remember this one? Okay, remember this one? Hayward, okay, basically in Boston Celtics. What's wrong with this guy? What's wrong with him? Anybody see anything wrong? Oh yeah, look at that ankle. It shouldn't be that way. The ankle, here's the tibia and the fibula come this way. Here's the foot coming this way. And basically that's the area of the medial malleolus. That's the inside of the tibia that's there. And he basically had what's called a fracture dislocation. So the foot went to the lateral side. I remember I was at that game. That was opening night a couple of years ago. It was a pretty innocuous play. He just went up, came down, and landed funny. Nobody really did anything. It was really like, didn't think much was happening. And all of a sudden, he's laying I see him laying on the court. Now, this was one end of I'm at the far end. I'm at the other end of the whole field house at that time. The arena, and I'm at the far end of the arena. And basically, I couldn't see what was happening. I just saw him there. And then what happens is the trainer that was down there ran down to get the Celtics trainer, which was down at the opposite side of the court, ran down to get him because he saw, that his ankle was like that. Obviously, he's having a little bit of a problem right there. Okay, but anyway, so I couldn't see it. And then what happens is a bunch of the security people surrounded him, so you couldn't see it. So my wife was at home. She wasn't at the game, so I called her and I says, hey, if you have pictures on TV when it happened, send them to me. She sent me, I got a picture that was very similar to this. So I was able to tell everybody in the stands what happened. He had a fracture dislocation. Okay. He's done for the night. Okay, he can come back. He came back. He came back the following year, but it takes a long time for those because they have to go ahead, put the joint back in. They have to probably put a couple screws in there to hold it in the right place, hold the bone in the right place, because for this to happen like that, the bone has to break as well. So they probably put a couple screws in there to hold it in the right place, put it in there. It takes a while for the ligaments to heal up together as well. Okay, so that's called a dislocation. That's called a dislocation. This is a ganglion. Okay, I've had a number of students recently ask me about their ganglion or family member that has a ganglion, and you can actually see the ganglion sitting right here. Okay, you see that big bump? Well, it looks like a bad thing. Now people say, I got this bone that sticks out right here. And I say, you know what? That's not a bone. That's a ganglion. If you actually touch it, it actually moves a little bit. You'll actually be able to slide it back and forth a little bit, move it forward, backward a little bit. And what this is as the tendon comes through an area or the joint, there's a little sac or a pouch that comes off the tendon's sheath. Tendon actually runs through a sheath, okay? So if we have the tendon right here, there's a sheath that surrounds the tendon, sort of like this. Yeah. And what happens is that the tendon moves back and forth. It has that sheath to protect it and allows that tendon to slide. Or if I have a joint, sometimes a little pouch that comes off a joint. Well, what happens is that tendon sheath, as well as the joint, is lined by what? Synovial membrane. What does the synovial membrane do? Make synovial fluid. So this is basically filled with a fluid material right there. Okay, and that's what causes this bump. Sometimes they're very hard. They almost feel like bone because they're so tight. So much fluid in there's tight, and the fluid's sort of like more like a gel. Okay, it's not very liquidy. It's very much like a gel. The old treatment, and I'm not recommending this, was they called it the Bible treatment because the Bible was the biggest book in the house. And they say, okay, just look that way, and they slam it and they break it. But they break the cyst because this is actually a cyst. They break it, and what happens is it's going to reform, and it reforms more with scars, so it's much more difficult to take care of. Surgically, they could be removed, but they could be like the tip of an iceberg. Sometimes they actually go down between the bones and all kinds of crazy things, but that's called a ganglion. Sometimes they're not dangerous. They don't cause a cancer or anything like that. Where they do become a problem is if sometimes they could erode away bone, they could actually wear the bone away, or they put pressure on either a nerve or something else that then causes a problem like that, which then requires them to go and take that. I saw one that was at the proximal end of the fibula laterally. They actually moved the fibula away from the tibia at the area of the knee. It was actually quite large. Sometimes I used to take care of these. You try to stick a needle in and suck it out, nothing's going to come out because the fluid's really thick. What I did is if somebody wanted immediate relief, sometimes I'd numb up a certain area. I'd go in and then take a little lidocaine and numb up a little area right there and take the biggest darn needle I could take that biggest darn needle, stick it through where I numbed it up, and then take the needle out. There'd be a hole, and I'd squeeze it, and all that goo would come out like toothpaste, would just sort of squirt out like toothpaste. And then I'd make it smaller. Then I'd inject it with a little bit of cortisone inside there to decrease the inflammation. But saying that if you want to take care of it, you have to go and surgically remove it, okay? Which I've done some of those, and they could be pretty complicated by the way that they go. But that's called a ganglion or ganglionic cyst, you might hear, okay? This is the next thing we have here is a herniated disc, okay? And we talked a little bit about this peripherally before, okay? Now, if I look at this, here's the vertebrae, here's a vertebral body right here, okay? And this area right here is the disc. Sometimes what happens, that disc is sort of like firm on the outside and soft and mushy on the inside. And sometimes when vertebrae gets compressed against the other by landing or jumping or something like that, some people will actually cause that disc to start to bulge. And you can see it right here, it bulges. Now here's that canal like I talked about before. This is the way it should be. There's this canal with the spinal cord that's in there. What happens if that disc pushes out like that, it bulges out. You can see it's bulging right there. What happens is at each portion of the spinal cord, we have nerves that will come out, this little hole on the side of the vertebrae. And what happens is that disc pushes against that, and that's what causes a lot of pain and shooting pain and stuff like that that may go to the limbs and stuff like that. So that's called a herniation of the nervovertebral disc. You know, sometimes they'll just have to go in. What they do is sometimes do what's called a laminectomy. They actually go in and remove a piece of that archway around the back of the vertebrae right here, just to give the nerve a little bit more room. Okay. Couple other pathological conditions. Lyme disease. Okay, Lyme disease is basically a disease. It's an inflammatory disease that does cause an inflammatory arthritis that will occur. Okay, and what's it caused by? Caused by ticks. Okay, and what we usually see is a lot of people don't remember getting bit by a deer. These are deer ticks. Okay, they don't remember, and the deer tick carries the organism that causes the Lyme disease. Okay, and they get bit, and they take it off, and they don't think about that. A number of weeks to sometimes months later, they develop a lesion that looks like a target. This is called a target lesion because it looks like a target. Okay, and basically, then they start to develop some joint pain and stuff like that. It can become a problem because it starts to wear away joints. So basically, that's what's called Lyme disease. Lyme disease. Okay. Sprain versus strain. You know, we talked a little about those words before. And a sprain would be a situation where I have a ligament that's torn. So a sprain means a ligament's torn. Here you can see some of the lateral ankle ligaments that are torn. Strain means a tear or rip or stretching in the muscle and tendon. And that's the difference between sprain and strain. Okay, lupus. I don't know if you know anybody with lupus, but lupus is could be a pretty nasty disease. There's a couple different types of lupus. There's one's called a discoid lupus, which only involves the skin. But systemic lupus erythematosus, or sometimes you'll see it listed as SLE, okay? SLE affects all kinds of organs. And basically, it's what I call connective tissue disorder. It causes problems with the kidneys. It causes arthritis, causes a change in the joints. The lupus can involve the heart. It can cause the membranes around the lungs and stuff like that. May cause some vascular problems. It causes what's called Raynaud's phenomenon, where they get in the cold and the fingers will get very white. They actually blanch because it causes the vessels to become spastic. They close and they don't provide blood supply to the tips of the fingers, and that's called Raynaud's phenomenon. What happens if you look at lupus? Basically, it's represented by, their logo is the shape of a butterfly. That's a bad butterfly. Okay, but what happens, really call that, is because people get what's called a butterfly rash or a malar rash, MALAR, which is revolving around the eyes. So here's a butterfly that comes like this. And that's commonly what they see with the systemic lupus erythematosus. The rash doesn't mean a whole lot, but what it does is it means that they very well have this SLE. They could test it by a number of different tests, and we'll talk about those later in regards to lab tests. Muscle tissue, we talked about this before. Again, muscle is about 50% of the body weight is from muscle. Actually, most muscle is still all these little what I call myofilaments. Okay. These little myofilaments or myofibrils. What happens is they're surrounded by a lot of water. So and we're so much muscle. The body is so much muscle. About 50% of the body weight is from muscle. Is from muscle weight. Okay. Study of muscle would be called myology, because myo is basically a word root combining form that means muscle. We also have either a word root, could be used as a word root, as well as a muscle prefix, which is sarco. Sarcolemma, which is basically the cell membrane or the plasma membrane of a muscle cell. Sarcoplasm, which is the cytoplasm of a muscle cell, the fluid inside. Sarcoplasmic reticulum, which is basically the endoplasmic reticulum of a muscle cell, which, if you haven't taken A&P or cell biology or anything, are small little channels that are inside the cell, inside the cytoplasm. Sarcomere would be the repeating structural units. If you look at a muscle, skeletal muscle, you have a sarcomere lined up against another sarcomere, lined up against another sarcomere, like that. Inside of these little filaments are all inside there that actually will shorten. They overlap each other. It actually causes the sarcomere to shorten, which then causes that contraction. So that's called a sarcomere. And then sarcoma, OMA, means a tumor. In this case, a sarcoma would be a muscle fiber type of a cancer. Okay. The body has over 600 muscles, okay, and a lot of these muscles do a lot of different things. And basically, we know what a muscle does, it connects bone to bone that provides movement, okay? So that's that. They also provide facial expression, everything we do. Interesting thing about facial muscles, okay, there are a number of muscles. If you sit there and look inside a mirror and make all kinds of faces, interesting thing is they don't have a muscle that goes bone to bone. They have a muscle that goes bone to skin, and because the end of the muscle is then inserted or attached into skin, that actually causes the skin to move, that provides facial expression. Okay, so most muscles go from bone to bone, but in the face it goes from bone, it's attached to the skull or parts of it, the facial bones, stuff like that, to the skin, and that's what causes my skin to move on my face, which is very different. Now, if you ever do a cadaver dissection, these facial muscles are really difficult to dissect out, and the reason why they're so difficult to dissect out is because they're attached to the skin. So you have to sort of like, cut them off the skin before you actually see where these facial muscles are. A couple words that I should mention, a couple medical terms I should mention, is origin and insertion. When we talk about a muscle, they talk about origin and insertion. Origin is where it starts, insertion where it goes to, where it attaches to. And they change according to the movement and stuff like that. So basically, if you look at where the muscle is the more stable, okay, where it's attached to at the beginning, stable, attached to start out with, that would be called the origin, and goes to another area which is called the insertion, which actually is the other bone that then will move on the first muscle. So this is the muscle that's stable. Usually the insertion goes to the muscle that goes to the bone that moves. Now there's a number of skeletal muscle actions, and these words are words you should know. First two are paired, flexion, extension. Up here you see flexion and extension right here. I can use flexion in other ways as well, okay? And basically this one right here is looking at the trunk flexion or extension. Now if I look at my picture here, if I look at my elbow, if I put it out this way, it's extended. If I bring it this way, it's flexed. Extension, flex. If I straighten my knee out, it's extension. If I bend my knee, it's flexion. Okay? Flexion means the angle between two bones gets less. Extension means the angle between two bones gets bigger. Okay? So that's flexion, extension. Abduction, adduction are the next two, and they basically paired and they're opposite each other, abduction and adduction. And we can see that down here, okay? Now, if we have that midline of the body, the midline of the body comes down this way. If something is moving away from that midline, it's called abduction. If it's moving toward the midline, it's called adduction. If I take my arm out and put it out to the side, I'm abducting my arm. But if I bring my arm in towards the side of my body, I'm adducting my arm. A lot of times you'll see instructors say AB duct or AD duct, because sometimes if I say abduction or adduction, it's hard to tell the difference if I'm speaking really fast. Okay, so that's our abduction and adduction. Dorsiflexion and plantar flexion, we see that down here. If you take your toes, okay, if you just look at your ankle and you bring your toes up towards your knee, okay, and you bring the toes up and you decrease the ankle. So if the ankle's like this, and if I bring the foot upwards this way, so now my ankle's like this, so the knee would be up in here, that's called dorsiflexion. If I point the toes downwards, that's called plantar flexion. Plantar flexion. So you can see the plantar flexion down here. Supination and pronation are very similar to what we see with inversion and eversion. Inversion and eversion are components of pronation and supination. If I take the bottom of my foot, if my foot was like this, okay, and if I take my foot and turn it in towards the midline of my body, turn it in towards the midline of my body, where the bottom of my foot, the plantar aspect, is pointing towards the midline like that, that's called inversion. Okay, it's also what we see as a component of supination. If I take my foot now and turn it outwards away from the midline of my body, that's called eversion, okay, or sometimes also called a component of what we see called pronation. People, when their arch gets flattened, they say their foot's pronated because the foot's sort of turned out. You can actually see how this would be the lateral aspect of the foot here. It's turning out this way. This is the medial aspect turning in. Okay, so that's that. So that's pronation, supination, inversion, eversion. Internal rotation and external rotation. And basically, you see with internal rotation is basically where if you look at here, this is probably the best way to look at it. Okay, if here's the leg, okay, if you look at the leg on this side right here, the leg is rotated outwards. The rotate is rotated outwards. If you take your straight leg and you take the foot and you rotate outwards, that's called external rotation. If I look here, I'm rotating the leg inwards, okay, and that's called internal rotation. So that's internal rotation, external rotation. Again, there's other flexion. Okay, but anyway, and then the last one we have here, okay, is circumduction. Circum means around, like circle. If I take my arm and turn my arm in all, circumduction is really basically a combination of a bunch of different motions together, okay? And basically that's making a big arc, you know, with your, you can do it with your leg, you do it with your arm, you do it with your thumb, you know, stuff like that, and all that would be called circumduction. So it's going around in a circle, okay, circumduction, okay? So that's another word you should know. All these are words. Couple more vocabulary words, okay? Fascia. When we look at fascia, now this is a muscle right here. It could be any muscle. If you look at this way, next time you get a roast, sit there and dissect it before you throw it in the oven. But what happens is I see a muscle belly sitting in here, but then there's all this white tissue, okay? All this white stuff, okay, that's sitting right here, that divides all these muscle bellies. And basically that's called fascia. And fascia is sort of like a bundle, like the bag that holds everything together, okay? There's a fascia that's around the outside of everything, and each individual bundle has fascia. And then if I look at smaller, when I have smaller muscle fibers, the muscle fibers are held together with also something called fascia. You know, so fascia is a binding type of a material. It's a connective tissue, dense connective tissue. You see it around there, all that white stuff that's around there that holds everything together. Could hold the whole group together, individual muscle as well as small muscle fibers, and that's called fascia. Okay. Sometimes people on the bottom of the foot, they have the heel that sits right here. They have this band of tissue that goes from the heel area, okay, to the forefoot, and that's called the plantar fascia because there's a band of really dense tissue. And some people are going to call it plantar fasciitis. Okay. We have to think about the difference between muscle, and that's what the rest of these vocabulary terms talk about. Striated muscle, okay. Striated muscle means striped. Okay, and if you look at the muscle here, and you must look at the muscle here, it's hard to see it in the lower picture, but these muscles are called striated. And if you look, see, and stripe, if you have all these little stripes that are going in this direction, yeah, you'd see it if you look closer here. And what those are is, I mentioned there's these little bands, these little filaments, and they overlap. And where they overlap, area becomes more like it becomes darker. And so what happens is you see these stripes. Now, if I talk about striated muscle, I'm talking about two types of muscle. Skeletal muscle, which is the muscle that produces motion, like biceps, triceps, quadriceps, hamstrings, stuff like that, as well as cardiac muscle. Cardiac muscle means heart muscle. These are both striated type muscles. They have a striped appearance when I look at them underneath the microscope. And again, that striped appearance, if I look at that, if I look at the fiber coming like this way, the striped appearance is coming like this way. So across that fiber. And that's because, again, I have filaments that are like this. And then what happens is between them, I have other filaments that they come across in between these gaps, like that. And right here where there's an overlap, and right here where it's overlapped, it looks like a stripe. Okay, and that's what we see in regards to striated muscle. And that would be both skeletal muscle and cardiac muscle are both striated or striped. Other type of muscle we have, okay, and I'm getting rid of myself down here so you can see a little bit better, is smooth muscle. Smooth muscle does not have striations. You can see down here, they look more spindle shaped. Okay, and this is the smooth muscle is what we see inside of blood vessels that cover organs, and that's why we are also called visceral, because visceral means what? Organ. Okay, so the visceral muscle is basically muscle that's around various organs. And when you're sitting there trying to be quiet, you hear that gurgling in your stomach. What happens is there's these smooth muscles are contracting and moving fluid through the small intestines just to try to move food around where it has to be. Okay, so smooth muscle does not have striations, and it's basically we see it in areas we really can't control. We can't control my cardiac muscle. It's called involuntary. Smooth muscle is also involuntary, but we see that smooth muscle in the walls of blood vessels, in the airways, they'll open and close the airways of my lungs, in the walls of my organs, they'll allow things to allow movement in those particular organs, and that would be what we call smooth muscle and visceral muscle. Okay, a couple combining forms that we have here that are pretty easy and they're, should be pretty simple. Fascia means fascia, and we talked about what fascia is. Fibro means fibrous connective tissue. Okay, fibromyalgia. Ooh, you probably heard that. Fibromyalgia. Fibro means fibrous. Myo means muscle. Algia means pain. Fibromyalgia is a condition where what happens is they think that the connective tissue that surrounds certain areas or bundles of muscle, fibro. Okay. Myalgia, okay, what happens is the connective tissue around the muscle becomes inflamed, and that's what causes a problem. Okay, so that's called fibro means fibrous connective tissue. Leiomyo means smooth muscle. Okay, we'll talk about this at the end of the year when we talk about the female reproductive system, but they have what's called a leiomyoma. And leiomyomas are these uterine fibroids because the uterus is basically smooth muscle, okay, to allow for uterine contractions for childbirth. What happens is smooth muscle, so what happens, they get a benign tumor of that smooth muscle, which is called a leiomyoma or uterine fibroids. Myo, we know, means muscle. Myocardio means heart muscle because myo, muscle, cardi, heart. Myoso also means muscle. Planto means the bottom of the foot, the plantar area. Rhabdomyo means skeletal muscle because rhabdo, like I mentioned, could either be a prefix or a word root that means skeletal muscle. Okay, and these are words that we've had before. Okay, a couple of suffixes and prefixes I think important. Asthenia means a lack of strength. Probably about 6 or 7 years ago, I was driving to see my son in Florida. I got down, we take 77 down. I got down to the area of Marietta, just at the southern Ohio border, just going across the bridge into West Virginia. And all of a sudden I started seeing double. But the double vision I saw was I see something here, I see something here. So if I saw a car here, I'd see a car on the top of it. And it just sort of occurred all of a sudden. So I thought something was wrong. I thought, well, am I having a stroke or something like that? So I keep on driving. My wife didn't tell my wife. Should have, but I didn't. That's what guys do. But what happens, I'm driving along and I'm doing a little cranial nerve exam of myself just to see if I'm doing, and everything else seemed to be functioning fine. But what happens, when I came back, I knew it was happening. I came back to Cleveland. I was down there for a week and I could see this double vision and stuff like that. It was like that for a while. You wore a patch, so therefore I would be able to drive, so I patched one eye so I didn't get the double vision. What happened was I went to my primary care doctor, and I went to ophthalmologist, and I went to a neurologist, and I have something called Acedia Gravis, which is not an uncommon thing. It's also an autoimmune disease where what happens is it attacks your immune system, attacks some of the receptors where the nerve and the muscle interact, and it causes a certain level of weakness. And the reason why I had this is because my eye muscles are commonly involved with that, and it causes that double vision. That double vision, actually, by the way, okay, probably a good word, we call diplopia. Di means two, opia means vision, okay, or visual. So that's a double vision, diplopia. Trophy is a word that we've had before, and trophy means development or nourishment, hypertrophy. When people don't use something for a while, in other words, when they're in a cast for a while, what they do is they come out of the cast and the leg or the arm looks smaller, and that would be called atrophy. Atrophy, which means without. A means without. It's a prefix we had before, without development or nourishment, and it gets smaller. Okay, a couple other prefixes that we have here. Some of them pretty. Ab means away from. We had that one before. Ad means toward. That's where we get abduction, away from the midline. Adduction, toward the midline. Dorsi means back, like dorsum. Okay, and poly means many or much. Okay. A couple lab tests and procedures and stuff like that. Arthrocentesis, and this is that arthrocentesis like we talked about before. You take a needle and stick it inside a joint and draw the fluid out, that we can look at what the fluid looks like. Okay. Arthrography. And arthrography basically is graphy means getting an image. What they do is here's a shoulder joint, so here's the humerus, here's the clavicle right here. And they just take a die, stick it inside the shoulder joint, and see where the die goes to see if there's a hole. If that capsule is torn, the die will leak out. So that's to do with arthrography. Arthroplasty, and arthroplasty is basically a surgical repair of a joint. Now, let's talked about this before. Here we have, here's the femur, here's the tibia, here's the patella right there, here's the fibula over here, and basically the joint's worn down. So what they do is the joint's worn down so the cartilage won't replace itself. What they do is they put a prosthetic piece here, they put a prosthetic piece right here, and reestablish it, and that would be called an arthroplasty. Arthro, joint, plasty, surgical repair. Sometimes they could just shave down at the sides if there's spikes, if there's spurs on both sides, whatever the case may be. Arthroplasty just means a surgical repair of a joint. Arthroscopy, okay? Arthroscopy is basically what they do is they take the joint. Now this is a knee arthroscope, okay? And what they do with that is they put in 3 portals. Put a portal here, portal here, portal here, okay? And basically one portal is to view, okay? There'd be a camera on one portal to do some work. What they have to stick an instrument in there to do something, and they have another portal to provide fluid material that goes inside there to keep the joint puffed up. Okay, to keep it sort of like blown up, so therefore it moves things apart. In other words, if they don't put the fluid in there and sort of blow up the knee with fluid like a water balloon, everything is against each other and you can't see anything. So to get between the joints, what they do is they fill it with a fluid, and with the water, okay, with the saline actually. And what happens is that allows the joints bones to move apart from each other so they can actually see what's going on, and that's called arthroscopy. Okay, so that's arthroscopy. It's a very common procedure, very short recovery time. They just go do that. That's why there'll be 3 or sometimes 4 little holes with that, because they have to get in multiple different portals to be able to do those things. This is bone density test, okay, or what's called sometimes bone densitometry. And basically what they do is they do a scan. There's a special way they do the scan with this densitometer. What they do is they measure the density of a bone, and they're looking for osteoporosis. And in this situation right here, this is where it came out. If you look right down in here, okay, this is where the bones scan the density, which was a problem. This is where it's good. This is where it's a little questionable, and this is where it's a problem. So I can actually scan the bone. They can do a number of different places. This is the radius, okay, which is a very good place to do it. The vertebrae they've looked at the hip. They look at the calcaneus a lot of times because it's accessible, but I don't think the studies really show that the calcaneus is a really good bone. We actually did a study through the Natural History Museum at that time, a number of years ago, probably about 15 years ago, 20 years ago, that says that the calcaneus is not a really good bone to be able to look at that. It's too much weight bearing. Okay. So that's called a bone density test. And they're looking for osteoporosis, with that. Okay, bone scan. And this is a bone scan. Okay, what the bone scan is, they inject a radionuclear material, okay, a radionucleotide, usually technetium or something like that. They inject it, and what happens is that technetium is bound to phosphate. That phosphate bond then binds to bone, and areas where the bone is being turned over comes out blacker. And this is, so if you see, there's around the ankle, around the knee, and this is normal. This side here is really normal. Here's the pelvis, here's the vertebrae, shoulders. Now if you look at this side over here, there's things that are abnormal. That should be there. It's the middle femur, that shouldn't be there. So that you're seeing this is just looking at the front and the back. We can also see the humerus, that shouldn't be there. There's little areas in the vertebrae that are in the ribs. What that means is now that cancer that started somewhere is going to other areas and affecting other areas of the bone. So this is called a bone scan. And they're able to see where bone is being turned over. They can look at this for fractures. They can look at it if they can't see a fracture, sometimes we do a bone scan. They look at cancer spreading, which is called metastasis and stuff like that. And that's what they use a bone scan for, okay? Not an uncommon test. Computed tomography, okay? And this is a CT scan. We look at a CT scan, basically what they do is it's an X-ray. CT scan is an X-ray. And what we actually see here, this thing around the outside, okay, there's an X-ray tube and it actually goes through. So what they do is they put a person on a tray and they slide that tray through this gantry and they do it a little bit, increment at a time. Choop, 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 choop. And every time they go through a little chunk, this X-ray beam goes around in a circle and takes a thin slice of an X-ray. So what happens is, what they look at a CT scan, there will be you'll see a large film, okay, with images that are lined up next to each other. Okay. And basically, these are all individual slices. So you're able to see something, even though X-rays only show 2 dimensions. You're able to almost recreate 3 dimensions by identifying one slice, and the next slice would be here. You can actually see where things go. So that's called a CT scan. Discography. Okay, this is also a CT scan right here. Let me go back. It's also a CT scan. This is a CT scan looking at the head, okay, at the skull, and you can see how it's taken in slices. So what happens is they stick the head in there and they go slice, 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 slice. So this is what's called a scout view up on the top. This is showing, if you look on there, you see all those little lines that are going back and forth like that? This shows all the individual scan levels. And they start low and they're going, they're just going and they're evaluating the whole, they evaluate the skull in all these different little levels. And that's what they're seeing. They're seeing one level, next level, next level, next level, or next level, next level, next level, next level, next level, next level, on and on and on and on and on. And then by doing that, they're able to determine where things are, okay? And they're able to almost get a 3-dimensional view of where how things are. Discography, okay? And discography involves the disc. Okay, we talked about the back and the herniated disc before, and that's what we're seeing here in this discography. What we're seeing is they're actually able to take, and these are needles, okay, all these little needles. What they do is they just put a little dye in there, and to see where the needle, where the dye is going. Like here's dye that's going outside the joint. This joint looks okay. This joint we see going outside, and that's just showing that there's some type of a rupture or herniation of the disc, that the fluid that's on the inside, okay, which is actually leaking out. Electromyography. Electromyography is basically another way of looking at nerve and muscle relationships. And what they do is they take these small little needles and insert them in muscles. And what they do is then they have them contract the muscles, and they're able to see electrical representation of what that muscle is doing when you contract. It'll be like this, and all of a sudden it'll contract, and you see they're able to look and see if the muscle is working by looking at how that muscle gets stimulated. Magnetic resonance imaging, okay, is a little bit different. And this looks like the same type of a thing that we saw before. What happens is this is a tube. So I stick you in this tube, and this tube has a magnet inside there. The magnet aligns your hydrogen atoms a little bit better, and then it hits it with a radio frequency signal and makes these hydrogen atoms do crazy things. They start to spin wildly. Then they turn the frequency off, and they get the energy that's absorbed by the atoms. It gets shot back, and they receive that there, and it gives an image. So basically, it looks like an X-ray, but it's not. It has nothing to do with X-ray. Okay, and this is what we look like. And this is looking at a knee. Okay, this is actually a pretty nice picture of a knee, and we're able to see not just bone, but we're able to see soft tissue. So here's the femur right here. Here's the patella right here. Here's the tibia right here. Okay, this area back in here is the gastroc muscle, the big large calf muscle that's back in here. And this right here, see that black line right there? You can't see it a little bit. That's one of the cruciate ligaments. That's a cruciate ligament right there. This white in here is fat. Here's the patellar tendon. The tendon goes from the patella. The quadriceps muscles are attached up here to the top of the patella. And continue as a tendon right here that attaches to a tibial tubercle right there. And that's you can actually see the tendon, that black line right there. You can actually see there's the patellar tendon. You can actually feel that as that cord. So let's look at magnetic resonance imaging. You can see a lot with that. You can see soft tissue, you can see bone, all kinds of different things. It's actually a pretty good tool. Okay, and then muscle biopsy. Okay, muscle biopsy is just taking a piece of muscle tissue, Okay, and there's lots of different ways to do it. They could do it open, they could do it in surgery, they could just go and make a cut and go inside. But sometimes they have this needle contraption. Okay, they look at this, they have a needle contraption like this. It has a big core. In other words, the needle is much larger, and the inside is a big core. So what they do is they stick the needle in the muscle they want to look at. They put a little suction on it, and it pulls out a core. Here's that needle right there. And what happens is there's a core of muscle tissue that was trapped inside that needle when they pulled it out. Okay, so they're up here, they're numbing it up, they're getting ready with the device right here. Here they're inserting that needle into that area of the muscle. They pull the needle out after they've had that core filled. It's sort of like when they look for, take and do a earth sample, and they take a core of earth. What they're doing the same thing here is the muscle. And then what happens is then they extrude that little core outside that muscle, and they can send that for some type of biopsy. Okay, a couple lab tests and stuff like that. I just want to do these briefly because I've gone a long time here. First one's called an ANA. ANA stands for anti-nuclear antibody, and basically this is a test looking for autoimmune diseases such as lupus. Okay, if you're going to do this ANA, they'll test for lupus. Erythrocyte sedimentation rate, and this is a test that looks for inflammation. What happens is if you take blood, you put it in a tube, and you let it sit, you come back the next day, and what happens is it's going to be dark red on the bottom, and it's going to be clear fluid on the top. That clear fluid on the top is a plasma. It's all fluid. The reason why it's red at the bottom is because cells have weight. So if it's 6 cells in a tube, eventually they're going to fall to the bottom. It's like if you're walking across a creek, you kick up a lot of mud on the bottom, come back an hour later, and it's clear again. Why? Because that mud will fall. What happens is when there's inflammation, the red blood cells that are in there that actually fall into the bottom of this tube get proteins on the surface of them that make them heavier, and they fall faster. And as a result, what causes a change in what's called the erythrocyte sedimentation rate. And they could actually look at that. So they use this test for looking for inflammation, because the inflammatory proteins then coat the surface of the red blood cells to make them heavier, and they fall faster. Rheumatoid factor. Rheumatoid factor is a test that's looking for. It's also sort of like looking for antibodies, and they're basically looking for rheumatoid arthritis. That's why I call it the rheumatoid factor. Serum calcium is looking for osteoporosis. So what happens is they look at the calcium. Again, calcium, people like this, is most important for bone. Wrong. Calcium is more important for things such as muscle contraction, nerve conduction, clotting, heart muscle contraction. And when I need it for those things, what happens is the body, through little glands in the back of the thyroid, called the parathyroid glands, remove the calcium from the bone and put it back into the serum or back into the blood. So they're able to look at the levels of serum calcium for looking at things like osteoporosis. Serum creatine kinase, and creatine kinase. Creatine is a different thing. Same thing. Creatinine is another thing that's similar to this. But creatine kinase is basically a muscle enzyme. Okay, and what happens is if I have a muscle disease, the muscle fibers get damaged, and they release this enzyme. So what happens is now this enzyme, because the muscle is damaged, it releases the enzyme. Where does it go? It goes in the blood. They're able to measure the levels of the CK, or the creatine kinase, in the blood. And if it's increased, it usually be some type of a muscle disease because the muscle is being damaged. Uric acid. Uric acid is that test for gout, those crystals that we talked about before. Okay. A couple abbreviations. AC joint stands for acromioclavicular joint. Stands for acromioclavicular joint, which is basically where the acromion meets the clavicle. Acromioclavicular joint. Okay. ACL, anterior cruciate ligament. Anterior cruciate ligament. Okay, which is inside the knee. ANA was a test we talked about before when they look at lupus. C1 through C7, cervical vertebrae first, the 7th cervical vertebrae. CA stands for calcium. CK, creatine kinase. CTS, carpal tunnel syndrome. Carpal tunnel syndrome. DEXA or DEXA, DXA, either DEXA or DEXA, stands for DEXA scan, which is basically looking for osteoporosis. That's that bone densitometry study that we talked about before. DMARD. DMARD stands for disease-modifying anti-rheumatic drugs. Things like anti-inflammatories, corticosteroids, and stuff like that are all called DMARDs, because what they do is they modify the inflammatory process that we see in things like rheumatoid arthritis. So I call DMARDs. DTRs. DTR stands for deep tendon reflexes. You ever notice when they tap your knee and your tibia shoots out? That's looking at the deep tendon reflexes for the patellar. It's called the patellar reflex. If they tap the back of your elbow, your arm will flex a little, will move a little bit, will straighten out a little bit. To attach the wrist, your wrist moves a little bit, and those are called deep tendon reflexes. Okay, and they look at that for looking for neurological disease and stuff like that. EMG, electromyography. We showed that picture before where they stick the needle in the muscle to see how it's actually functioning. ESR is called the erythrocyte sedimentation rate. I talked about the SED rate before, the sedimentation rate before, and basically erythrocyte means red blood cell, and that's why those red blood cells drop. Okay, IM, intramuscular. If they give an IM injection, it's intramuscular inside the muscle. L1 through L5, again, lumbar vertebrae. Okay, L1 through L5, and we talked about this. We have cervical vertebrae, we have 7. Thoracic vertebrae, we have 12. Lumbar vertebrae, I have 5. Sacrum, I have 1. Coccyx, I have 1. Okay, so basically L1 through L4 would be L1 would be the first lumbar, L2 would be the second lumbar, through L3 all the way up to L5, which would be the 5th lumbar vertebrae. Just like the C1 would be the first cervical, C7 would be the 7th cervical vertebrae. Okay, I think these are numbers you probably should know. So what we've talked about here is talk about muscle and joint conditions. Okay, pretty much covered it all. Everything I think it's worthwhile knowing. There are a number of words in here that you probably need to know. So we talked a little about joint formation, the different types of joints, various terminology and vocabulary that's involved with that, and we talked about muscle. So hopefully this filled in all the other blanks that we talked about when we talked about the musculoskeletal system. In previous videos we talked about the skeletal system and skeletal terminology and stuff like that, but now we're just talking about muscle. And so hopefully this will help you a lot. Okay, we'll talk to you again later on, so study hard and learn a lot, and we'll talk to you later. Be safe, be healthy.